Cannot start the video. Sorry. Hello. Hi. A very good morning to everyone. On behalf of the organizing committee, we welcome you to the webinar. My name is Siu Hua, a committee member of the Rheumatology Nurse Chapter. I'll be the moderator and the MCs for the public Zoom webinar. We are happy to see many of you have shown interest to know more about arthritis, especially in younger age group. We are honored to have two expertise speakers that have special interest in pediatric and young adults, arthritis among the complex rheumatology condition. Today, we have collaborated with Singapore General Hospital and KK Women and Children Hospital to bring you this exciting event. Before we begin, I have two housekeeping notes. Today's session is being recorded to be available for viewing post-conference. If you have any question for the speaker, please use the Q&A chat feature as told. Type out all your question. We will address the question after each speaker. We will now call upon Ms. Yi Shaoling, the chairperson for Rheumatoid Nurse Chapter, to provide her welcome speech. Ms. Yi, please.
Thank you, Siu Hua. A very good morning to everyone. Great to have all of you here on Saturday morning. This is our first public webinar that we organized, a collaboration between Rheumatology Nurses Chapter together with SGH, KKH, and NUH. We organized this in conjunction with World Arthritis Day, which is held annually on 12 October, with the aim to create awareness about arthritis disease. Hope you will understand from today's talk that arthritis not only affects the elderly, but can affect children, younger adults as well. Before I pass over to Siu Hua, I would like to thank our two distinguished speakers, our committee members, and SGH Patient Liaison Service team for making this event possible. Hope you have a fruitful session. Over to you, Siu Hua.
Thank you for the opening speech, Ms. Yi. Today's topic is focused on the arthritis in children and young adults. I'm sure you're eagerly waiting to hear from our panels of experts. Let's get the webinar started. First, we are grateful to have Dr. Tay Kai Liang, a consultant rheumatologist from KK Women and Children's Hospital. Dr. Tay is graduated from NUS Yonglulin School of Medicine in 2011. He joined the SingHealth Pediatric Residency Program in KK Women and Children Hospital, where he was elected as the Chief Residency. In 8 years' time, he has gone to the specialized training and get the expert as consultant in Department of Rheumatology Peds subspecialty in KK Women Children Hospital. He is actively participate in clinical education, research work in the local common rheumatic diseases, transitional care, and young adult in rheumatology. Now let's welcome to Dr. Tay to share with us his topic on juvenile idiopathic arthritis, short form because JIA, in local experiences in treating JIA. Now let us welcome Dr. Tay to share the screen. Thank you, Dr. Tay.
Okay, hi, a very good morning. So thank you for the kind introduction. I'm Dr. Tay from KK Women's and Children's Hospital, and I'll first like to thank the Rheumatology Nurses Chapter for the invitation to give this talk on juvenile idiopathic arthritis, or JIA in short, and also to share our local experience in treating JIA. Now, one of the most common thing that we hear in our clinic is that, oh, you mean children can also get arthritis? I thought only elderly people can get arthritis. Okay, so I hope that with today's talk, I will be able to shed some light on JIA and raise awareness on what JIA is. I will also be sharing the demographics of our local patients, how we manage our JIA patients and the outcomes of them. So to start off, what is JIA? Juvenile idiopathic arthritis is a form of arthritis in children, and arthritis just means inflammation in the joint, and this results in joint swelling and joint stiffness. Now, because it is a childhood onset of arthritis, so the onset must be less than 16 years old and affects one or more joints for at least 6 weeks. So anything shorter than 6 weeks, it may just be a very transient thing, like for example, due to injury or just a very mild reaction of the joint to certain infection. Okay, so the joint must be affected for at least 6 weeks or more. The local incidence is estimated to be about 5 to 6 per 100,000 children yearly, but this is data consolidated a few years ago, and we think that this number is slowly going up, mainly because of increasing awareness of GIA. So what causes GIA? The exact cause is unknown, and people say that it is a mix of genetic and environmental factors. But what we do know is that it is classified as an autoimmune or autoinflammatory disease, meaning that certain components of the inflammatory pathway actually get too activated and attack the joint. And if this inflammation goes unchecked, then there's destruction of the joint and erosions into the bone. Clinical features of GIA include joint swelling, morning stiffness, joint pain, and limping. And you can see that pain features quite heavily in the clinical features of GIA. But in children, they are very active. They are always, bumping into things. So how do we differentiate between inflammatory joint pain and mechanical joint pain? Inflammatory joint pain are usually insidious in onset with a gradual limitation of movement, so it comes on quite slowly. One of the hallmarks is that there is morning stiffness and pain, and the pain is usually worse in the morning. Okay, so we see a lot of the common complaint is that, the patient wakes up, cannot get out from the bed, or that they have difficulties holding the toothbrush and shower head. As opposed to mechanical pain, the onset is usually quite acute with a preceding traumatic event. There's abrupt limitation of movement, there is absent morning stiffness, and the pain is usually at night after a whole day of activity or after a long day of walking. But it's important, and as pediatrician, I always stress this, that children are not small adults. Okay, so sometimes the symptoms can be very vague and non-specific. Pediatric patients usually have difficulty in localizing the site of pain. And more importantly, the lack of reported pain does not exclude arthritis. Okay, so we have seen that there are children that come in without any much complaint of pain, but parents notice that they are limping or that they are not walking normally. So we always ask parents to observe them during their normal activities, like during play, schoolwork, sleep, and see how they behave. And sometimes that may bring more information than just the symptoms of pain. So what pain features quite heavily in the diagnosis of GIA, not all joint pains are GIA. So I'm just going to share with you a few cases that come to see me for joint pain, but in the end, the diagnosis turned out to be something else. So this is an 8-year-old Chinese boy who came in with limping for the past 3 days. He has a non-productive cough, runny nose, no fever. He complains of leg pain and walks with a limp, but the parents do not recall any history of trauma, and there is also no family history of arthritis or autoimmune condition. And on examination, when we checked, there is actually no swelling of his joints. Okay, so this is actually how he walks. And you can see clearly he's limping, okay, but there is no joint swelling. So we suspected that there's something wrong with the hip. And indeed, when we did the ultrasound scan, it showed that there's some fluid accumulation in the hip. So we gave him a course of non-steroidal anti-inflammatory drug like the Brufen group of medicine, and he recovered quite well without any recurrence. So we diagnosed this patient as transient synovitis, which is just a very transient reactive joint arthritis to usually a flu or a diarrhea kind of infection. And this normally doesn't recur, so it is not GIA. The second case is a 5-year-old Chinese boy with persistent elbow pain for the past 4 weeks. He was placed on a cast by the emergency department. But despite taking a lot of painkillers, he continued to have pain, waking up multiple times in tears because of joint pain, and does not allow people to touch or move his joint. And on examination, the elbow joint actually appears swollen. So this is a normal X-ray on the left. You can see that there is actually no, it's very well-defined kind of border in the X-ray, whereas on the right, okay, so I have pointed out on the arrow that you can see that the border of the X-ray actually has this double line. Okay, so whenever this happens, we worry something sinister in the bone, like either a bone infection or a blood cancer. And indeed, when we referred to the oncology team and further workup, it did show that he had multiple blood cancer cells, and this patient turns out to have leukemia. And the last case is a 14-year-old Chinese girl that came to see me with multiple joint pain for the past 8 weeks associated with morning stiffness. She had difficulties holding the brush every morning, but the stiffness gets better throughout the day. And despite taking analgesia, her joint pain persisted. So this history sounds like a very inflammatory kind of joint pain, like I mentioned before. And when we examined, indeed, she did have joint swelling over her knees as well as the finger joint. Now, what we do notice on further examination is that she also have got oral ulcers and malar rash, which is this butterfly-like rash on the cheeks. And further investigation showed that she has some antibodies. So this patient turns out to have systemic lupus erythematosus, which is actually a systemic autoimmune condition. Okay, so arthritis can also be a feature of systemic autoimmune condition. So not all joint pain and arthritis are just GIA. So when I say that not all joint pain are GIA, the reverse is also true. GIA is not just about joint pain. Certain subtypes of GIA can also present with rash, and there is also a close link between juvenile idiopathic arthritis and the gastrointestinal tract. So some of the patients actually have got inflammation in their intestines, so they present with chronic diarrhea. I mentioned about swelling, and there are two other areas that also have got joints, but people don't really think about it so often. So one part is the buttock. Okay, and with the joints there are inflamed, then the patients can present with buttock pain. And the other area is the jaw, the temporomandibular joint. And if that is inflamed, then patients can either have jaw pain or they have difficulty opening their mouth. There is also a close association between GIA as well as eye inflammation. So some of the patients actually come in with visual disturbance or eye redness, known as uveitis. Now, GIA is not a single condition. There are different subtypes, okay? And the latest classification criteria classifies GIA into 7 different subtypes. And I will go through a little bit in detail in each of the subtypes. The first 2 subtypes are the oligoarticular type. So the oligoarticular type affects 4 or fewer joints at onset. And typically the large joints are affected, the knees, the ankles, and the elbows. And they are further classified into extended or persistent oligo-GIA. So the extended form is when there is more than 4 joints as time goes by. The persistent oligoarticular GIA is just when there is still 4 or fewer joints, even as the patient disease continues. And this may sometimes be associated with positive antibody with a very high risk of eye inflammation. The next 2 types are the polyarticular type, which affects 5 or more joints at onset, and usually affects both sides of the body. Both large and small joints can be affected, and further classified into rheumatoid factor positive or rheumatoid factor negative GIA. The rheumatoid factor positive GIA are actually the adult form of rheumatoid arthritis. The next type is the enthesitis-related arthritis, and this, other than arthritis, involves the enthesis, where muscles, ligaments, or tendons attach to the bone. So I show some examples here, like behind the heel, there's the Achilles tendon that inserts into the bone. And on the sole of the foot, there's also the plantar fascia that attach to the bone. And these areas can get inflamed. We call it enthesitis. Now, in patients with ERA, there is also one other joint, the pelvic bone, known as the sacroiliac joint, that can also get inflamed. So like I mentioned, patients typically present with buttock pain. ERA typically affects boys more than 6 years old, and sometimes they may get a positive gene called the HLA-B27 gene. Okay, the next type is the systemic GIA, which affects not just arthritis, but the entire body, including the skin and the internal organs. The patients usually present with high spiking fever, rash, enlarged liver, spleen, and enlarged lymph nodes. And sometimes the diagnosis can be quite difficult early on because these systemic features may precede the onset of arthritis. And then next is psoriatic arthritis. So other than arthritis, they may also get this psoriatic rash, which is this erythematous red plaque-like rash on the skin with these silvery white scales. And these rashes usually appear in areas where it's sun hidden. Okay, so like along the hairline, behind the ears, elbows, belly button, scalp, etc. The skin symptoms can come on before the onset of joint symptoms, and some of the patients also get new changes like this pitting as shown in this picture. Okay, so to share our local demographics, 60% of our patients are males and 40% are females, and the racial distribution is slightly different from the general population. While the majority are still Chinese, but we have slightly more Indians compared to Malay having GIA, and 14% others, which includes Caucasian and other Southeast Asian as well as Eastern Asian. Now, The types of arthritis, the GIA, actually differ according to the different geographic location. So locally, we see a lot more ERA patients, followed closely by the oligopersistent arthritis. We don't really have a lot of rheumatoid factor positive polyarthritis and psoriatic arthritis. Okay, like I mentioned, the subtypes actually differ according to different geographic location. Okay, so if you see in Singapore, 33% of our patients are ERA, but compared to the West, they have actually only about 8 to 12% of the patients having ERA. And even within the Asian population, okay, like Hong Kong, China, they don't really have a lot of ERA. In reverse, Western population actually have a lot more polyarthritis, okay, and we don't really have that much locally. And in China, they have a lot more systemic arthritis. So our distribution of the GIA mimics a little bit more like the Taiwan population, where they also have a lot more ERAs, not so much of a polyarticular as well as the systemic form of arthritis. So why do we want to treat GIA? Now, if without treatment, GIA can cause a lot of pain, causing functional impairment. Because of joint destruction, it can cause deformities. And children are that different from adults. Children are still growing. So if the joints are destroyed, they get limb length discrepancy and a lot of functional impairment. They get osteoporosis, fracture, and these all incur a lot of financial cost. The immediate treatment goal is to reduce inflammation, relieve discomfort, preserve function, and also prevent deformities. Whereas long-term management, we want to achieve control of the disease while minimizing side effect of the medication. We want to promote normal growth, development, and also functional activity. Now, traditionally, this is how we treat GIA. So there is what we call a step-like approach, where we start off with medication like NSAID, and if that does not work, then we move up the step, going into other medication called conventional DMARD, biologic DMARD, synthetic DMARD. And bridging this entire treatment strategy is steroid, which can come in the form of oral injection or injection into the joint itself called intra-articular steroid injection. But for children, we don't really like to use steroid for a long period of time because it does affect their growth and development. So most of the time, we want to move on quite quickly to conventional DMARD, biologic DMARD, and synthetic DMARD. Now, with treatment as technology move on, this ladder we no longer want to sort of like move them up because in children we tend to be a bit more aggressive in the treatment. We don't want their joints to get affected. Okay, so sometimes depending on how they present, we may immediately start off with biologic or synthetic DMARD. And also, as more evidence are being discovered, we do know that certain subtypes of GIA, they don't respond so well to conventional DMARD. Okay, so this is no longer more like a step up, whereas it's just depending on the patient's presentation, we would decide at which level they need the treatment. So methotrexate and sulfasalazine are two of the most common conventional DMARDs, and I present here our local data in terms of the types of conventional DMARD and biologic DMARD that we use. So you can see a lot of our patients are still on conventional DMARD, partly because this data was collected in 2020, and before this, we actually need to document we have failure of conventional DMARD for at least 3 months before financial assistance can be given for those biologics. Okay, so right now, I think that this is starting slowly to change, mainly because there are more cost efficient biologics that are coming up. And we also know that biologics work better for certain subtypes of GIA. So more and more biologics are being used compared to conventional DMARD for certain subtypes. Okay, so I mentioned a lot about biologics. So what are biologics? These are a group of drugs that are produced by biological engineering that target specific molecules in the inflammatory pathway. And because they are produced by biological engineering, quite a lot of them are very expensive. Now, these are some of the examples, and they can come in pen form, like insulin, so the children or the parents can actually do the injection themselves at home. So this is quite convenient. In the pediatric population, I think one of the challenges that we face is that compared to adults, very few drugs are actually approved for use in children. Okay, so we have actually very limited options when it comes to biologic treatment for pediatric patients. But I do hope that as more and more biologics are being discovered and as more research is being done, we have more options as more of these drugs are being approved. And I also mentioned that a lot of these biologics are costly. Again, this is likely going to change in the upcoming years because we have biosimilars. And biosimilars are products that are similar to the FDA-approved biologic product, but has no clinical meaningful differences in terms of their safety and effectiveness. Okay, so I think the concern is always whether these biosimilars work as well as the originator. So I present here a study from Germany where they start off patients with the original biologic known as Embro, and after treatment, they switch over to biosimilar. And the lines here represent the disease activity score. The higher the score, the worse the disease activity. So you can see that even after they switch the patient to biosimilar, there is actually not much in terms of increased disease activity. So similarly for our local patient, we also have done similar study. And I just want to summarize that there is no differences in terms of responses and disease course between the original biologic and biosimilar. And even after we switch our patients to biosimilar, there is no significant flare. Okay, so with this, I hope that there is more and more cost-effective options for us to use in children. Now, the next question we get is that do children outgrow GIA? Okay, so you can see here the probability of GIA patients achieving clinical inactive disease, meaning that their joints become quiet. Okay, so for 5 years, actually quite good data, about 80–90+% of our patients do achieve clinical disease at least once. Certain subtypes more so than the others. But while they can achieve clinical inactive disease, actually quite a lot of them may not be able to achieve remission of medication. Okay, remission of medication, we define them as inactive disease for 6 months without any medication. Okay, so this is the light blue bar, and you can see that certain subtypes like the polyarthritis, rheumatoid factor positive ones, and the undifferentiated ones, they seldom go into remission of medication. So some of these patients still need to be transited over to adults as they continue to be managed by our adult rheumatologists. So even after attaining clinical inactive disease, 50% of them may flare. And even after stopping medication, if they do manage to stop their medication, about a third of them will flare. Okay, so they still need close monitoring. And if they flare, we may still need to then put them back on medication. Now, if the patients want to flare, about a quarter of them will flare within the first 6 months, and almost all of them would flare within the first 5 years. So we always tell our patients that if the first 5 years after stopping medication, you do not have flare, then there's a very good chance that the arthritis, you have kind of outgrown it, and the chance of it recurring is very, very low. Okay, so this is what we get from our local data. Then the next question the parents always pose to us is there any harm in terms of long-term treatment, right? Because with all these flares, with this waxing and waning pattern, a lot of patients need to be on pretty long-term medication. Any harm in doing so? So this is actually a study done to look at cancer risk, okay? Because a lot of these biologics, if you Google, one of the concerns is always whether they cause cancer or not. So this is comparing our GIA patients with a control cohort. And you can see that for those patients that are not exposed to any medication, they are actually already at higher risk of having cancer because of ongoing inflammation. In fact, if you treat the patient with MTX or biologics, this risk decreases. Okay, so GIA itself carries an increased malignancy risk if left untreated. And if you weigh that risk of using treatment, they actually decrease the risk because you control the inflammation. So I always tell the patients that not treating the GIA carries more harm than treating the GIA. Okay, so can our patients actually, what is their functional outcome and whether they can go on to do normal exercises? And I can tell you that some of our patients are actually national athletes. The whole point of treating our patient is so that they achieve normal functional outcome and they can go about doing their normal activities as per usual. And in terms of diet, I always stress that for pediatrics, the balanced and healthy diet is important because they are still growing. So there are a lot of research out there on anti-inflammatory diet. We don't recommend them for our patients, mainly because they are still growing and some of these diets are quite restrictive. In terms of vaccination, there is also a lot of publications on vaccine recommendation for pediatric patients. So the few things, one, vaccination is preferred during quiescent disease. So we don't like to vaccinate them when their arthritis are still active. And if possible, vaccination should be administered 2 to 4 weeks before starting any immunosuppression. But if the patient comes in with frank arthritis, there is certain urgency in treating, then we don't delay the treatment. We still go ahead with immunosuppression. Then subsequently, when the disease is inactive, we will catch up the vaccine. While the patient is on immunosuppression, non-live vaccines can be given. So these are like tetanus, diphtheria, whereas live attenuated vaccines should be avoided, except MMR and varicella vaccine. Okay, so MMR varicella vaccine can still be given safely. Now, seasonal influenza vaccine, pneumococcal vaccine, and HPV, these are not part of the compulsory national immunization schedule, but we still recommend for all our patients because while on immunosuppression, their immune system obviously will be slightly weaker and they are more prone to these infections. So we still recommend that they go for their yearly influenza vaccine and they have up-to-date pneumococcal and HPV vaccination. And lastly, for uveitis screen, and like I said, there's a close association between GIA patients as well as uveitis, inflammation of the eye. So these patients do need to go for eye screening every 3 months if they are high risk, especially those young ones, and if they are early on in their disease duration, or 6 to 12 months if they are moderate or low risk. Okay, so like I mentioned, that a lot of patients, they do see us and we follow them for a long period of time, and some of these patients may still go on to have medication and they need to be transited over to the adult rheumatologist. So in KK, we have a structured transition program where we start to prepare them for transition once they reach about 15, 16 years old. We assess their readiness and then subsequently we prepare them to transit over to the adult rheumatologist. Okay, so I also want to share with you some of the findings that we get from our own transition program when we assess their knowledge as well as their readiness to go over. What are some of the barriers in transitioning them? So our local patients, okay, are actually, the red ones actually means that less than 50% of them are able to do so. The green ones are those that are more than 75% able to do so. So our patients actually don't perform so well in terms of knowing their health insurance plan. They don't really understand how healthcare privacy changes as an adult. And also, I guess they do not really talk with their family members on them making their own healthcare decisions. Whereas they are relatively good in terms of navigating the healthcare system. Like for example, they know where to get their blood work or x-rays, they know what are their allergies to medication, they know what is their medical need and what is their medicine, okay? And also in terms of their readiness, so you can see that a lot of them are not ready in terms of knowing their healthcare insurance coverage, their financial help if they do need one, whereas they are better in terms of their managing of their own day-to-day life, like for example, keeping their own home and room clean, taking their own home medications, as well as asking questions to the healthcare providers. Okay, so I always tell parents that as the patient grows older, and I guess this applies to a lot of other chronic conditions, parents should start to prepare their children by talking to them about some of these financial things, which we don't normally talk a lot in the Asian context. Okay, so some of the take-home messages that arthritis can also occur in kids and adolescents. Early diagnosis and treatment of GIA is key in ensuring no long-term complications. I hope that with new drugs that are being discovered and more biosimilars that are being produced, this will provide pediatric patients with better treatment options and better outcomes. I also want to stress that non-pharmacological management is equally important. And with treatment, the goal is that GIA patients can also perform normal physical activities without affecting their lifestyle too much. Okay, and with that, I would like to thank the whole clinical team, including the pharmacists, our physiotherapists, occupational therapists, and also our research team from the translation institution that helps us a lot in terms of coming up with a lot of these data. Okay, thank you.
Thank you, Dr. Tay. It's very excellent talk and very informative. Okay, we in the public, we have known that all the young children in pain, we just don't know what to do. Now we believe with this, we very benefited from your knowledge. I'm sure now we are spread among others that they pay more attention to the children. Now we have enthusiastic question coming, Dr. Tay. So some, I believe that just now the slide have gone through, they might miss out. So one important question coming is that about the patient can go back to sports and the diet, what can bring under control, and any food to avoid. Dr. Tay?
Yeah, so I mentioned that children with arthritis, as long as their joints are being controlled, they should be able to return to normal sports. And in fact, a lot of our patients are athletes. Okay, so special diet wise, we don't recommend them. because children, they are still growing, so we don't want them to be restricted in terms of their vitamins, in terms of their nutrition. So a healthy, balanced diet is still what we recommend for all our patients. Okay, but of course, weight management is one thing that we also focus on as they're growing up, because we don't want them to get too obese. That is not so healthy for the joints as well. Yeah.
Great, thank you. Dr. T, just like you will say the ERA, that's in our Southeast Asia, a bit more question from me, that high incidence, is that to do with obesity, overweight in Singapore?
No, I don't think so. That is got nothing to do with our obesity. ERAs, there is a certain genetic predisposition. I mentioned about the HLA-D27 gene. Okay, so it is slightly higher in prevalence in Taiwan population, in India, as well as local, which is why we see a lot more ERA patients compared to the Western population. And interestingly, not all Asians are similar, because you can see that the Chinese population in China, they don't get a lot of ERA as well. Okay, so that has more to do with genetic predisposition rather than obesity.
Thank you. Now we have one last question. I think we shall answer to the one anonymous attendees. She said, my 14 years old girl complains of foot pain near to the ankles. Brought her to KKH, but doctors say it's due to the mild flat foot. Oh, that's very common, but she still complains pain, at times limping. Will her condition very related to JRA unnoticed?
Yeah.
Dr. Tay, please. Yeah.
I think this is a very common complaint for parents to bring them to polyclinic and also subsequently refer to us. So the first thing I want to stress is that there's difference between the inflammatory pain as well as mechanical pain. Okay, so like I mentioned, if a patient has got a lot of morning stiffness, morning pain symptoms, even without activity, then that is something that is worrying. The second point is that these arthritis pain are usually persistent. They don't come and go very fast. Right, so if the pain and the limping persist for 3 days and above, then I think it's also better to seek medical attention. Whereas if the pain comes and go, like for example, at the end of the day, sometimes the patient comes back and say that, oh, I got pain. They are still able to run, they are still able to walk as per usual. A little bit of massage makes the pain better. And the next day they wake up, they are well. Then this probably is just mechanical, a lot of muscle pain, and you can just monitor them for a while. Okay, but in any case, if the patient is walking funnily, I always say take a video down and then seek medical attention. Then at least the doctors can assess for ourselves whether this is true limping, whether there's a need for assessment of the joint. And a lot of it is still examination by the doctors to see whether the joints are inflamed and involved or not. Okay.
Okay. In view of the catching up with time, we have to end this Q&A. I know you have a last question, because this is really, we keep your burning question till the end of session if you have more time. Sorry. Thank you again, Dr. Tay. We will now move on to the next speaker, none other than Prof. Our senior consultant in SGH, Professor Warren Fong. He's very actively participate in the care of inflammatory arthritis amongst all the rheumatoid diseases. He did his clinical trial in Department of Rheumatology Hospital in Southampton in UK and Essex. Then his keen interest really lies in inflammatory arthritis, in particular spondyloarthritis. He was principal investigator for the research, looking at the biologic agent, just now we heard about biologic, in ankylosing spondylitis, as well as the principal PI for study looking in the use of complementary medicine in axial spondyloarthritis. It's my pleasure to welcome Prof. Lawrence. He will be sharing with us the topic more than just back pain, is that the label for spondyloarthritis. Without much delay, we shall pass the screen for Prof. Fong. Thank you.
Thank you, Silva. Just give me a moment. Okay. Good morning to all. If you can see my screen. So the talk is entitled More Than Just Back Pains, Spondyloarthritis. Okay, and this disease is known by many names. It's also known as ankylosing spondylitis or axial spondyloarthritis. So for today, we'll just use the short form SPA, SPA for short. Okay, and what I'm going to cover is that we are going to talk about what this SPA is all about. Okay, signs and symptoms of SPA, and treatment options for this disease as well. Okay. And before we go further, okay, so a little bit of trivia to get everyone excited. You know, you can see 4 people here. Dan Reynolds, okay, he's actually a singer, okay, from this rock group called Imagine Dragons, okay. Jay Chou, Zhou Jielun, okay. Tiger Woods and Clement Lim, he's our own former national swimmer. And he won gold medals in the Southeast Asian Games in 2013 and 15. So if you all hazard a guess, okay, who is the odd one out, you know? And if you are thinking Tiger Woods, you are absolutely right, because all the other 3 people have this very rare condition called axial spondyloarthritis, or SPA for short. Okay, and Tiger Woods has degeneration. So today we are going to dispel some myths that patients and the public have mentioned in my years of treating spondyloarthritis or SPA. And myth number 1 is that axial spondyloarthritis and osteoarthritis, which is commonly known as degenerative arthritis, are the same conditions. Okay, and the answer is no. Okay, so what are some of the differences between both conditions? So in axial spondyloarthritis or SPA, okay, patients typically are younger, okay, so you have heard that they can start from the age of 6, and in adults, we often see them between the ages of 20 to 30 at first presentation, and both males and females can be equally affected. Whereas in osteoarthritis, which is degeneration, patients tend to be older, typically more than 50 years old, and females are a little bit more affected than males. Okay, and in terms of SPA, okay, you can see that, you know, less than 1 per 100 people are affected, as compared to patients with osteoarthritis. You can see that many more patients actually have osteoarthritis. Okay, in both conditions, Chinese are predominantly affected in our local population. Okay, and there's a bit more predominance in patients with SPA compared to osteoarthritis. The next difference is that SPA patients can actually have fusion of the spine. Okay, and this is not seen in patients with just degeneration or osteoarthritis. So you can see here that the entire spine can actually be affected, okay, including the sacroiliac joints, as Dr. Tay has earlier alluded to. So what happens is, over a period of 5 to 10 years, you can see that the joint spaces between the spine actually all fused up, okay, and that can cause severe mobility issues. You can see that in the past, when we didn't have treatment, okay, the patient from a normal back posture, okay, will get more and more curved as his spine fuses up. Okay. So osteoarthritis, typically we call it degeneration, okay, where there are these bony spurs or osteophytes that come out, okay, they impinge on the nerve, and then that's how you get back pain. So there's prolapse of the disc, it pinches on the nerve, and then you get these shooting pains that come on, especially when you bend forward, when you pick up heavy loads, for example. Okay, and as Dr. Tay alluded to, this is very different from patients with SPA, okay, where they tend to have early morning stiffness. Okay, so in degeneration of the spine, okay, you can see all these things poking out when we do the X-rays. Okay, so these are the osteophytes or degeneration seen. Okay, and it's very different. It doesn't fuse up the spine. Okay, it doesn't join in one straight line. Okay, so myth number 2. Early on, you heard about this thing called the HLA-B27 gene, right? So a lot of people think that, oh, okay, like all genetic diseases, if you have the gene, you will definitely have SPA. Okay, again, this is not true. So if all the patients with SPA conditions, okay, typically about 85 to 90% of them actually have the gene, okay? But having said that, okay, if you were to look at the children, then not all of them actually go on to develop SPA. Okay, only about 10% with the gene actually go on to develop SPA. And if, let's say, everyone goes for a health screen and then they happen to do the HLA-B27 in these patients, okay, then only 2% actually go on to have disease. Okay, so having the gene does not equal to having the disease. And typically, in parents who have the gene, okay, we do tell them that in your kids, you should not screen them for the gene, okay, because majority of the time, your child actually does not go on to have disease, okay, but there will be problems when they actually apply for insurance coverage. Okay, the third myth that is SPA patients only, have back pain and nothing else. Okay, and again, similarly to children, okay, SPA does like the back a lot, okay, and the reason why this is so is because you can see that there are a lot of all these tendons, and the area where the tendon joins onto the bone, okay, this is called the anticil site. Okay, and in our body, there are a lot of cells that make all these inflammatory cytokines, the little orange circles. Okay, and what happens is that inflammation then collects at these anticil sites. Okay, so a lot of the times when young adults complain of back pain, there is nothing really that people can pick up or see. Okay, no, and sometimes you might even wonder, are these people sort of malingering or telling some weird story of their pains? Okay, and that's the reason because of that is that a lot of the inflammation is not seen. It's all at the anticil site, and you can imagine that your whole spine is full of this. Okay, so that's why back pain is such a predominant feature. And as alluded to earlier, patients can also have what we call peripheral arthritis. So their joints can be swollen, okay, for example, in the knee. Okay, you can also have a swelling in the hands. Okay, you see this joint is markedly swollen. Okay, the nails can be damaged as well. Okay, and the whole digit of the finger can be swollen too. Okay, so these are the nails. Again, there's this thing called nail pits. Okay, the little dots seen on the nail. Okay, and at some of them, the nail is very badly damaged. Okay, they can also have this condition called psoriasis. So these are what we call salmon pink patches. Okay, so very pinkish on the skin. Okay, they can have it over the hairline as well, around the navel region and the groin, for example. Okay, and they can also have this thickened Achilles tendon. So if you look at their foot at the back, you can see that this whole area here on both feet are all swollen. Okay, and this is psoriasis as well. So a lot of patients who are adults also have inflammation of the eye. So about half of the patients can actually have inflammation of the eye at some point of the disease. Okay, but thankfully it tends to be easily treatable with topical steroids. Okay, and the intestines can also be inflamed, and they can have this condition called inflammatory bowel disease. Okay, and so what is myth number 4? So myth number 4 is that, because they are relatively well, you don't see much things right in the spine. They have little impact on patients' life. Okay, so again, this is a myth, so that's not true. So locally and as well as internationally, you can see that a lot of the patients are affected in many things that we take for granted. For example, interrupted sleep, okay? Close to 90% of our patients have interrupted sleep. They have problems carrying things like groceries, okay, for energy for social activity is reduced. Even simple things like putting on socks, climbing stairs, it's a problem, okay? Getting in and out of chairs, you can see that close to 40% actually have problems doing this, okay? And if you look, we compared this to patients on dialysis, and you can see that our patients actually have even more pain than patients undergoing blood hemodialysis, okay, blood washing. Okay, so this is a very significant disease, and there's a significant burden and reduced quality of life in patients with SPA. Okay, so myth number 5, okay, exercise makes SPA worse. Okay, so again, this is false. And exercise has been shown to be very beneficial in patients with SPA. Okay, there are numerous trials that are well conducted. Okay, and you can see that function is actually improved in 80% of the patients. Okay, and pain and stiffness is what most of our patients suffer from. Okay, can have more than 90% improvement in these symptoms. Okay, so exercise is very much encouraged. Okay, and you know, you don't have to do it for too long, about 20 minutes each time. Okay, 2 to 3 times a week. Okay, that'll be very sufficient. Okay, myth number 6, okay, that there's no treatment for SPA. Okay, again, that is false. Okay, so treatment is now very possible. Okay, so in the past, you saw earlier that patients get hunched. Okay, they have a very bad back. Okay, but now you have people that are actors, that are singers, that are swimmers. Okay, so treatment has really evolved. Okay, and the backbone of treatment is really exercise and physiotherapy. Okay, and we also get our other allied health involved as well. So patients with problems in finger joints, for example, we get the occupational therapist involved. Patients with foot pain or heel pain, the podiatrist can get involved, for example. Okay, we have very good patient support groups. Okay, and subsidies for needy patients. Okay, and physiotherapy or exercise is very important because that alone reduces the inflammation very significantly. Okay, and in those patients who then, you know, still need an additional help. Okay, so that's where my medications come in. Okay, so we typically use painkillers, is commonly known to the public. Okay, called NSAIDs. Okay, so these are easily available in the polyclinic, be it things like Voltaren or diclofenac, okay, or naproxen or Simplex. Okay, and in patients who have very bad pains affecting, for example, the knees or the hands and fingers, then typically we can even use oral medication called sulfasalazine, as some of you might be on. Okay, and that reduces the inflammation very significantly. Okay. And of course, thankfully nowadays, you know, for the past 20 over years, we have very much better advanced therapies. Okay, and things that we commonly use are these group of medications called biologics that Dr. Tay alluded to earlier. Okay, and thankfully in adults, we have a little bit more medications in our arsenal, including this new oral class of drugs called targeted synthetic DMARDs, or disease-modifying anti-rheumatic drugs called Janus kinase inhibitors. Okay, but if you need this, your doctor will definitely discuss this with you in detail. Okay, and there's a lot of you know, a worry whenever it comes to stronger medications or drugs, or especially injections, right? Okay, but people need to know that, you know, the medications are really very, very effective. Okay, so you can see that, you know, 80% the bone formation actually stops or is very much reduced. Okay, and there's significantly less pain and stiffness in the patients who are suffering from these. Okay, and when they conducted the clinical trials, which are very stringent in terms of monitoring of the patients, okay, infection rates, which is something that our patients are very concerned about, actually is similar between the patients on biologics and those that are not. Okay, for spondyloarthritis or SPA. Okay, and as Dr. Tay alluded to, you know, malignancy risk is actually not higher in those patients who are treated. And in fact, you know, there's actually a 50% reduction in the risk of prostate cancer. So that bodes good news for the males. Okay, fertility is not affected, especially in males. Okay, it can be safely used in pregnancy. Okay, although we do advise that if patients use the medication in pregnancy, then in their children, for the first 6 months, we'll delay some of the vaccinations, but the medication is not harmful to the children. Okay, and you can see that there's no increase in miscarriages or malformations of the kid. Okay, and you can even use it safely in breastfeeding because it's not passed on to the child at all. And in the past, you know, we couldn't do surgery, but technology has really advanced. And nowadays, okay, corrective surgery is even possible, okay, in advanced disease. And of course, we must continue treatment of the underlying disease, okay, whilst undergoing treatment. Yeah. Okay, so myth number 7. So pain in the back, okay, is in the young person is normal. So again, no. Okay. So when do we worry? Okay, if you're really a young person, okay, and you have this persistent back pain, every morning, like Dr. Tay said, okay, that happens every day, okay, persistently, for 3 months or more, then we should get it investigated. And this pain is very peculiar. So typically what most patients will be able to tell me is that, as they move about, then this pain miraculously gets better. And whenever there are long periods of inactivity, this pain is very strange. It keeps coming back. Okay, and this pattern is very persistent. Okay, it's not happening on one day, goes off the other day. Every day it's like that. Okay, and so we'll come to have the end of the talk and some take-home messages. I hope that patients with symptoms do seek medical attention early, because this is really a very easily treatable disease. Okay, there's lots of medications and exercise that we can prescribe. Okay, and really you can live your dream to its fullest. Okay, there's nothing that's really holding you back. Okay. And with that, just to do a little fundraising that our department is doing, okay, if you would like to help make it better for other patients or for people that you know with this condition, if you can just scan the QR code and make a little kind donation, we'll be most grateful. Thank you very much, and I'll be open to any questions. Thank you.
Excellent talks, Prof. It is very informative, but that pain is very common in the young, yes, but we know that the treatment fidelity is there, but facility that some patients was wishing, that's like the question say, can we leave the arthritis without taking any medicine? Can we just non-pharmaceutical way, go by exercise itself? Is there a way?
Yes, this is a very good question, and actually that's something that a lot of the patients do ask me. Okay, so the good news is that yes, not everyone with SPA. Okay, so this specifically only for SPA patients that we are talking about. Okay, so not everyone needs to be on medications, because you can see that exercise alone, regular exercise, actually does reduce the inflammation. Okay, and in real world data from my clinic, okay, about a third of my patients actually are not on any medications at all. Okay, but the caveat to it is that you do need to continue regular physical activity, or else there is a chance that the spondyloarthritis can come back and recur. And we saw it most, significantly during the COVID lockdown periods, right? Where everyone couldn't sort of go out, people were stuck at home. Yeah, so if they did not do their own home exercise or move around too much, okay, or they start this prolonged working from home, okay, then they realize that, oh, their symptoms sort of come back.
Okay, there's one more question. For adult, if you are placed on biologic, will you be? Will it be able to slowly wean off the medication?
Yes, that's a very good question. Again, that's commonly asked. So the answer to that is yes. Okay. So typically, people who are very successful with weaning off the biologics will be those that are very motivated. So they are doing, their own exercises regularly. Okay. The other thing that we look out for is that they must be in this thing called disease remission. Okay. And so one is that they must have very little or no symptoms, preferably. Okay, they must have normal blood tests, so their inflammatory markers have to be normal. Okay, and when they look at their x-rays, they don't have any high-risk features. So high-risk features are defined by, for example, extra bone that's growing, what we call the syndesmophytes, that causes fusion of the spine. So in this group of patients, then the chance of them coming off the biologics or even reducing the dose is very much increased. Okay, and that's something that we also do in reality as well, where we tell people to slowly lengthen the interval between the biologics. Okay, but we do warn them that there are people who do flare. okay, and that's seen. And so they have to know their symptoms very well, okay, in order to do that. Okay, and of course, this is always a discussion between your physician and yourself.
Thank you, Prof. So there's one very common question. They say, if I have back pain, do I go to polyclinic and get a referral to see a rheumatologist? But just now in earlier part of the session, we have flashed out all the referral points from polyclinic, from the GP. Anyone can just refer in that to a rheumatologist or orthopedic. They'll be assigned and they will see what is the needed to be done. Thank you. Now we come for another question. Can a patient with this arthritis, can they drive? Because they have restriction of turning their back. Do we need to certify for this person fitness for the driving?
Okay, so it depends. Okay, for heavy vehicles, definitely you need to be certified. Okay, because if there's restriction in your neck movement, you can have difficulty in looking at your blind spots. Okay, but for normal day-to-day driving of your car, for example, okay, then there are many ways that you can overcome the limitation of movement of the neck. Okay, so for example, you can get special long mirrors to look at the back. Okay, and there are special mirrors that you can put on your side mirror to allow you to look and check your blind spot. Okay, so these challenges are more easily overcome nowadays. We can even modify the car to let you get in and out of the car more easily as well. Okay, and you know, nowadays they have special parking lots that have more widely spaced so that it's easier for you to get out of the car as well.
Good, thank you. So at least they know what is called injury prevention. Get into accident. Thank you. We still have 2 more minutes to go. We can have one more question. I'm so sorry, was one more question. Any burning question? I believe in between the speakers have tried to type and answering your question. Thank you very much, Dr. Tay and Prof. Now, one last question. Can the patient have SPA develop into, I mean, from JIA patient, can they develop into SPA?
Yeah,
I mean,
so
yeah.
I think as Dr. Tay alluded to, there are different types of JIA. Okay, so the enthesitis related arthritis, the ERAs, okay, especially if they have the HLA-B27 gene, then this sort of typically go on, and then you know, in the adults, they have almost the same phenotype as our SPA patients, and thankfully the treatment is largely similar.
Thank you. As the time is catching up, I believe that give us a second more, the doctor will type in the answer for your question, through question out. So now on closing notes, on behalf of the organizing committee and the entire workforce, we would like to take this opportunity to thank you, all of you, for attending this webinar. You have been a great attendees. We encourage you to provide us your feedback after this webinar ends. To the excellent speakers, thank you very much for the informative sharing. My name is Siu Hua, and I'm now signing off. Once again, thank you for joining us, and wish all have a wonderful weekend. Thank you. Bye-bye.